this before, and I'll again emphasize this, that genotype 3 is a very unique infection for several reasons. Historically, it's had lower sustained virologic response rates than other genotypes. We heard from Professor Tanwani that there's increased incidence of HCC compared to non-genotype 3. There's accelerated fibrosis progression compared to other genotypes. There's an increased risk of overall mortality. They have increased prevalence of hepatic steatosis, and in certain parts of the world, it is a major genotype like you all encounter here. So this is an important infection. Prior, like in the era of interferon and ribavirin, genotype 1 was the more difficult to treat. But with the era of directly acting antivirals, genotype 1 is not a challenging infection, and genotype 3 became the more challenging infection to treat. So there are various recommendations for treating this infection. You use sofosbuvir and weight-based ribavirin for 24 weeks. Encladisvir and sofosbuvir is a good combination. 12 weeks for those without cirrhosis, 24 weeks for those with cirrhosis, with or without ribavirin, although based on an allied 3+ study, the duration could be challenged to where the truncated treatment to 12 or 16 weeks. I'd like to see what Professor Foster has to say about it. And then you could also use interferon, ribavirin, and sofosbuvir based on a study called the Boson study, which again Graham was the architect of. So one thing I want to point out is that ledipasvir is not a good drug against genotype 3. If you look at EC50s of the various NS5A inhibitors, ledipasvir is the highest EC50. Encladisvir is a great drug, and an upcoming drug called velpatasvir, a pan-genotypic NS5A inhibitor, is a good drug. Granted, there is a small study, again from New Zealand, where ledipasvir and sofosbuvir has worked against genotype 3. I would be a little cautious about using ledipasvir and sofosbuvir. And if you had encladisvir available, that would be the better choice in treating genotype 3 patients if you want to pursue all oral therapy. Genotype 6, while it is common here, there's relatively sparse data on the efficacy of these directly acting antivirals in genotype 6. I showed this to you earlier, the 12-week regimen of PEG, ribavirin, and sofosbuvir was looked at in genotype 6. And here, there were only 7 patients, 5 and 6 in fact. Less than half of those were genotype 6, and they achieved high sustained response. Now, this is a small study looking at sofosbuvir and ledipasvir for 12 weeks in genotype 6 patients. There were 25 patients treated for 12 weeks, and there were about 2 cirrhotics of the 25, and the sustained response was 96%. Which suggests that this combination could work well in genotype 6 patients. So with that background, what are the newer treatments you can look forward to? There's one that has just been approved in the US. It's a protease inhibitor and an NS5A inhibitor combination. Ruzapavir is a protease inhibitor that has efficacy against 1 and 4, to a lesser extent 6, and elbasvir is an NS5A inhibitor, and they've looked at this combination with or without ribavirin in a variety of populations: cirrhotics, non-cirrhotics, HIV co-infected, and chronic kidney disease patients. And this will present another option to our patients, and you can see here genotype 1A patients had a 92% sustained virologic response, 1B 99%, and genotype 6, 80%, although there were only 10 patients in this study. So this is another option for particularly genotype 1 and 4 patients, and may present an option for genotype 6, although it's not likely to have a label for genotype 6. the combination therapy that is eagerly anticipated for approval this year is this one, a pan-genotypic NS5 inhibitor called Rilparencel, and the NUC NS5 inhibitor, sofosbuvir. It's been looked at across all genotypes, 1, 2, 3, 4, and 6, and also in patients with child class B cirrhosis. And here you can see the results from this one study that had 644 patients, and of 624, 618 achieved sustained virologic response. It's 1 pill a day for 12 weeks, regardless of the genotype. And you can see here, if you look at genotype 6, there are 41 patients, all 41 achieved sustained virologic response. You look at 1A, it had 98%, and 1B, 99% sustained virologic response. Now then, a trial was done exclusively in genotype 3 patients. About 277 were randomized to 12 weeks of sofosbuvir and rilparencel, and then the comparator was the standard therapy of sofosbuvir and ribavirin, but for 24 weeks. So this is 12 weeks combination versus 24 weeks of sofosbuvir and ribavirin. And you can see here a sustained virologic response that was statistically significant, 95% versus 80% in the standard of care. And here, what is more important is, in the past, sofosbuvir-based regimen had not done well in cirrhotics and treatment-experienced patients. But if you were to look at a breakdown of patients by cirrhosis or prior treatment history, or whether naive or treatment experience, look at these light-colored bars, 90% or higher of the patients who were treated with 12 weeks of sofosbuvir and rilparencel achieved sustained virologic response. So this tells you that even genotype 3, hopefully by the end of this year, is not going to be a challenge where you would see high sustained response rates with all oral therapy. So what are we working on now? Well, you have such great regimens, high sustained response. Now we're trying to push the envelope a bit in terms of decreasing the duration of therapy. And the question that remains is, what is the shortest duration of therapy that you could go with that has the highest response? And it appears that 90% is the bar, and anything above 90% would be acceptable. Anything below 90% in terms of SVR would be a challenge to accept. So we're working on pan-genotypic protease inhibitor, NS5 inhibitor, and the NUC NS5 inhibitor to see if we can shorten the duration of therapy. Other purpose of these strategies is to try and have a backup strategy for those who fail current treatments. It has become evident now that patients are failing, a few patients are failing current treatments even with combination pills because of emergence of NS5A resistance. In fact, for that matter, with crisaborole and remdesivir for 1A, NS5A resistance has to be tested before embarking on such therapy, because presence of NS5A resistance in the background has been associated with compromised response. So you'll hear more and more about resistance, as to how to avoid resistance and how to treat those who develop resistance. Well, while we've come across great treatments, we still have some challenges. So we try to climb up the mountain towards cure. We have boulders coming down and pushing the patients down and preventing them from achieving a cure. And what are the barriers to successful HCV treatment? There's several barriers. It depends on where you are, in which part of the world. In certain parts of the world, cost and payer resistance might be a huge challenge. In certain parts of the world, screening and diagnosis is suboptimal. Acceptance might be a challenge. Compliance, as we move forward, compliance in treat particularly large cohorts of patients will be a challenge. And then there may not be adequate number of treaters out there to treat hepatitis C infection. So if you were to look at certain regions of the world, at least in the area of NfL, you'll find something very interesting. On the x-axis, you have diagnosis rate, and on the y-axis, you have the treatment rate. And the larger the bubble, the greater the population. And if you were to look at India, it's really pathetic in that the diagnosis rate is the lowest and the treatment rate is the lowest. France has done exceptionally well, and Professor Dumont may provide some insight as to why France has done so well, in that the diagnosis rate is high and the treatment rate is high. I'm not even sure where Myanmar stands, and for that matter, I can't see any other countries in this region listed here to get a sense of what the diagnosis rate might be and what the treatment rate might be. So while we have great treatments, what good is it if you're not able to diagnose and treat these patients? And of course, another big barrier is the cost. It's a huge cost. You know, there have been major protests in the U.S. about the cost, and there are still now some that complain quite a bit about the cost. It's the cost of sofosbuvir-based regimen was $84,000. Whereas in Egypt it was only $900, so much so that patients from certain parts of the world were traveling to areas where you could get these drugs at a relatively low price. And this was shared by a Brazilian hepatologist with me, where a patient of his went to India to get sofosbuvir. As you can see, it is Indian sofosbuvir. It's in Hindi there. And the price is 19,900 rupees. That translates to $285 for 1 month in India. But if you were to look at the same thing in the US, it's about $28,000. So we, I think, have made great progress in treating hepatitis C. I never thought in my lifetime I would see it, but I must say I saw it, because when I started as an investigator, I used to give interferon 1 million units 3 times a week for 6 months, where we had ALT as a surrogate for response and not even HCV RNA. And we've come to this time point where we actually can cure hepatitis C. These are very effective drugs, very well tolerated, but there's still some barriers in terms of screening and diagnosis and access to these medications. So that's where the challenge is going to be. Well, I'll stop here, and thank you very much for your attention.
Thank you, Professor Reddy, for sharing us the use of DEAs, the new DEAs, and price comparisons. We in Myanmar are quite lucky. We are the neighbors with India. So, I think I can allow a few questions about DEA to Dr. Reddy's. Any questions? So any questions to Professor Reddy? Okay. You tell us very clearly about the use of DEAs according to the genotypes and the genotypic DEA ledibosphere. So let us thank Dr. Reddy for his contribution. Thank you very much.